Welcome, good morning, good afternoon, good evening, wherever you're tuning in from. Thank you for tuning in and welcome to today's Facebook Live Neurology for Vets, the Journal Club series. Thanks to Hallmark Advanced Veterinary Imaging for sponsoring this series. And as many of you know, this Journal Club series is an opportunity that we give to the rising stars of our profession to discuss their recently published work, and often for me to mispronounce their names, but I will try to do better. As you'll see that Laurent has left us for a far more attractive version of someone. And this is Ines Guerrera, and many of you know as a queen of neuroimaging. Welcome, Ines. Laurent is around. He's in the background doing the technological stuff and probably drinking. Anyway, we'll move on from there because it is my great pleasure to welcome Dr. Benedict Amfimac. Welcome, Benedict. I'm going to introduce you now. I was just making sure that I pronounce your name appropriately because it doesn't go well for me sometimes. Anyway, Dr. Amfimac is a diplomat of the European College of Veterinary Diagnostic Imaging. She was born in the French Caribbean island of Martinique, where she spent her early childhood, and already I'm very jealous of this. So moved to the southwest of France. Benedict is a 2017 graduate of Vet Agro Sup, Campus Vétérinaire, oh, it's terrible, de Lyon in France. After a year Erasmus in University College Dublin and multiple externships at European and North American veterinary schools, she completed a small animal rotating internship in Paris in one of the busiest French referral centers. Right after that, she was accepted into a 4-year radiology residency at Bern Vet Suisse Fakultät in Switzerland. She is the author and co-author of numerous scientific publications in international veterinary journals with a special focus on neuroimaging. Benedict spends her time either scuba diving in the clear blue waters of her native island or hiking the snowy peaks of the Swiss Alps. Yet again, very jealous. Her hobbies include music, fashion and art, and you'll find her hopping on a plane or riding a Dutch warm-blood stallion called Quickjack. Benedict, I don't know how you have time for all of this, but this is fantastic. It's very good work-life balance here. Fantastic. Anyway, welcome, Benedict. It is a pleasure, honor to have you here, as you say, as one of our rising stars. And today, you're going to present your work on the MRI grading of oligodendrogliomas. So we're going to hand it over to you, if that's okay.
Thank you so much, Simon, for this really kind introduction. So I'm just gonna. Okay. So good evening, everybody. It is really my pleasure to present to you this paper and to have been selected to do it. Thank you, Simon, for this kind introduction. Indeed, I am a European diplomat in diagnostic imaging. I was trained and I'm still based in Switzerland, where this paper is coming from. It was a collaboration between radiology department as well as neurology department and also neuropathology. So I would like to thank them for their collaboration in this study. As well, this study was my residency project, so I'm pretty excited to be sharing it with such a big crowd. And I hope you can enjoy it, and I hope it can also be of some help for those of you who are preparing for board exams. So I'm just gonna get to it. So for tonight, this is the plan that I'm gonna follow. I'm gonna talk about the background of the study and especially why did we choose to study such a disease and this topic. Then I'm going to explain to you the design of the study, the results that we got, and then there's going to be time for the discussion. And hopefully you will get some questions for me that I will address later. So first thing first, the background. So as Simon mentioned, the topic of my study was canine oligodendroglioma. And the first thing that I should do would be to define what it is, right? So it is a brain tumor that belongs to the group of glioma, which is just simply saying that it originates from the glial cells that are responsible for supporting and protecting the nerve cells in the brain and in the spinal cord. So it affects dogs. And in the literature, we can find up to 22% of primary brain tumors that are oligodendroglioma, which is quite a high number. There are a few predisposed breeds, namely the boxers that we can see here in this video, but also the Frenchies and the Boston Terriers. All of these breeds are very popular in Switzerland, which is probably the reason why we are so often exposed to it. Unfortunately, as many other primary brain tumors, it doesn't have any specific clinical signs. So the clinical signs that are reported are often seizures, but also pacing, circling, disorientation, as we can see on the video from this dog that was named Macho. And so that is why it's not so easy to make the diagnosis before going through more advanced imaging modalities such as MRI. Canine oligodendroglioma grossly looks like this picture. So it is often a very big mass that is located in the brain. It is intraaxial, and it is soft, and often it has these areas of necrosis and hemorrhage within it. There have been many descriptions of features of canine oligodendroglioma on MRI. Here I put an example of a T2-weighted sequence where we can see again this large, well-demarcated ovoid intraaxial mass that is T2 hyperintense relative to normal gray matter. And it has also been described that it can show variable amount of enhancement after contrast administration. Regarding the classification of canine oligodendroglioma, so in accordance to the WHO classification, the classification was revised recently in 2018, and there have been a definition of two groups of oligodendroglioma, two grades. The low grade, which is also called the grade 2, and the high grade, which is also called the grade 3. And to reach the diagnosis of a low versus high grade oligodendroglioma, two main histological features are important. These features are first microvascular proliferation and second necrosis. And the revised classification says that as soon as we get one of these two key features within the slide of this tumor, then we can conclude that it is a high-grade oligodendroglioma. In the absence of one of these features, we go back to the more normal features that are used to define malignancy in tumors, meaning the high mitotic figures or other characteristics such as anisokaryosis or anisocytosis, or these characteristics that are not specific for oligodendroglioma. So if we summarize and if we look really at this revised classification, we find out that microvascular proliferation and necrosis can alone be enough to reach the diagnosis of a high-grade oligodendroglioma. And interestingly enough, in human literature, microvascular proliferation has been associated with enhancement on post-contrast MRI. So this is a little bit the base of why we started to study this topic, because we thought that if we could reach an MRI feature that correlates with one of these two main histological features, then we would be able to establish a grading system that could be done on MRI. So the question that may arise right now is, what would be the point of being able to grade an oligodendroglioma simply on MRI? And actually, the point is that in humans, low-grade glioma are associated with a longer survival time and a better response to the treatment. So as often we do in veterinary medicine, we thought that maybe it would be the same in dogs, and maybe we could reach this kind of conclusions as well in our species. In dogs, there have been many studies prior to mine that have tried to establish MRI features related to gliomas grade and types, but unfortunately, no clear MRI feature have been defined so far to distinguish between low and high grades and between gliomas, meaning astrocytomas and oligodendrogliomas. And probably one of the reasons why this has not been reached before is that in all these studies, oligodendrogliomas and astrocytomas were just put together and studied as one group of gliomas. But from our personal clinical experience, it seems that oligodendrogliomas and astrocytomas are not really behaving the same, and already their classification are quite different. As I said, in oligodendrogliomas, we have these 2 grades, and in astrocytomas, there are 3 grades, which is already a little bit more complex. So the point of the study was, okay, we thought that if we could find reliable MRI features of high or low-grade oligodendroglioma, we could reach 2 goals. The first one would be to allow for future prospective studies, testing for survival time and treatment response, a little bit the same way that it has been done in human medicine, and try to see if the same would apply to dogs. And the second goal would be to serve as a surrogacy when, in case of brain biopsies, and when the histopathological examination is not enough to conclude on the grade of glioma. This is why the aims of this study were first to describe MRI features of dogs with confirmed oligodendroglioma. Second, to investigate associations between MRI features and grading of oligodendrogliomas. And for this, our main hypothesis was that contrast enhancement would be an indicator of microvascular proliferation and therefore be a discriminative MRI feature of high-grade oligodendrogliomas. So that's what we did. For our studies, we followed this path in terms of case selection and inclusion criteria. So it was a retrospective study. We went through the neuropathology database from 2004 to 2019. And our 2 inclusion criteria were a definitive diagnosis of oligodendroglioma and an available MRI of the brain. We therefore did 3 steps. The first one was an histological examination of the slides, because as I mentioned, the classification had been revised in 2018. So we had board-certified pathologists reviewed all the slides and performed the diagnosis of oligodendroglioma and the grading of the oligodendroglioma following this new classification scheme. The second step of the study was to do the MRI evaluation. And for this, we had blinded board-certified radiologists looking at all the MRIs and following very specific criteria that were predefined. This then brought us to the third step of the study, which was trying to establish any correlation between the histological features and the MRI findings. A little bit more precision about the MRI features evaluation. So we followed the criteria that were already used before in the literature, meaning the morphology of the tumor, the topography of the tumor, its signal intensity on all available sequences. And we looked as well for the presence of cystic structures, any contact with the ventricle that we tried to characterize as precise as possible. And then, of course, we had a main focus on the post-contrast appearance of these tumors, because we had this hypothesis that contrast enhancement would be the key parameter, the key criteria to reach a conclusion. So in terms of contrast enhancement, we looked at the severity of the enhancement and defined as none, mild, or moderate to marked. And then we looked at the pattern of enhancement. And of course, when we talk about pattern of enhancement in the context of gliomas in general, we have this typical ring enhancement pattern that have been described in the previous literature. So we for sure also looked at this specific pattern. And I gave you an example of this pattern on the right side of the image to see how it can look like on MRI. Then we performed a statistical analysis using the tumor grade as binary outcome, either low versus high grade, and all these MRI criteria as explanatory variables. So, results. In terms of neuropathology, we had 32 confirmed cases of oligodendroglioma, which is a lot if we compare to previous studies where they, in general, had about 30 cases of gliomas in general, with oligodendrogliomas and astrocytomas together. And among these 32 oligodendroglioma, 24 of them were high grades. And interestingly, all of the high-grade oligodendroglioma in our study population showed microvascular proliferation. So you can find on the right side of the screen, I gave you an example of the gross appearance, but also the slides from one typical high-grade oligodendroglioma. And I also put back this revised classification, which is also the base of all our hypotheses. And we can see that this is really important, that in our study population, all of the high grade were showing microvascular proliferation, which means that none of the other features were used to reach the diagnosis of a high grade oligodendroglioma in our study population. And then, of course, we had 8 low grade, and of course, none of those showed any microvascular proliferation. So, in terms of the MRI feature evaluation, the most common characteristics showed by our population of oligodendroglioma were this well-defined, ovoid, smoothly marginated, intraaxial masses that most of them had were located in the cerebrum, with the frontal lobe that was probably the most popular or the most affected lobe. And in our 32 oligodendrogliomas, 29 of them showed contrast enhancement. So now, regarding the association between MRI and grade, we had all of our high-grade oligodendroglioma showed moderate to marked severity of enhancement after contrast administration. All of the ones without any contrast enhancement were low grades oligodendrogliomas. all of the ones that showed a ring pattern of enhancement belong to the high grades. And a ring enhancement was never seen in a low-grade oligodendroglioma. There were other features, other MRI features that showed association with the grade. These features were the tumor heterogeneity on the pre-contrast sequences, the presence of areas of necrosis, the presence of signal voids on the gradient echo sequences, and the presence of cystic structures among the tumor. So if I get back to our population, now we can see how a typical high grade and a typical low grade below oligodendroglioma look like in our study population. So for the first one, we see this beautiful, well-defined ovoid mass surrounded by edema, showing a very heterogeneous pattern before contrast on T2 and flare sequences, and after contrast showing this complete, strong enhancement, peripheral ring enhancement. And as for the low grade that is located below, we show that it is also very well demarcated, large mass that is rather homogeneous on all sequences, and that doesn't show any contrast enhancement. So then for our discussion, we were quite happy to see these results and to see that contrast enhancement seemed to be really the key criteria on MRI to distinguish between low and high grade oligodendroglioma. And when we performed the correlation or tried to perform a correlation between the histology and the MRI, we also could establish a very good correlation between the histological areas of microvascular proliferation and the imaging areas of contrast enhancement. So that was really interesting for us. And I put on this slide, you can see an example of the image, the MRI on top, and below the histological slides with and without microvascular proliferation. So the first conclusion was that contrast enhancement is very specific for high-grade oligodendroglioma in dogs. And that was quite clear in our study because that's just what we observed. And one hypothesis is that all high grade that we had in our studies showed microvascular proliferation on histology. And this microvascular proliferation is known to cause a tear or rupture of the blood-brain barrier, which we know can be a reason why you get such a strong contrast enhancement. Moderate to marked contrast enhancement areas match really, really well with areas of microvascular proliferation on histology and are both really specific for high-grade oligodendrogliomas. So at this stage of the presentation, you're probably thinking, okay, this is almost too good to be true, because it seems really simple then to distinguish between a low and a high grade, or at least to make the diagnosis of a high grade oligodendroglioma. Because as soon as I see this moderate to marked contrast enhancement, as soon as I see a ring pattern of enhancement, I should be comfortable to say that this is a high grade oligodendroglioma. But it is a little bit too good to be true because, of course, we focus our population group was only made of confirmed cases of oligodendroglioma. And I said it in the beginning that previous studies that could not reach such a conclusion had a mixture of oligodendrogliomas and astrocytomas. So it was on purpose that we chose to study specifically oligodendrogliomas because we thought that they were just behaving differently than astrocytomas. So now the next challenge is to make the diagnosis, even presumptive diagnosis of oligodendroglioma. And for this, we need to distinguish it from other intracranial disease. Thankfully, MRI has shown very good sensitivity and specificity to do so. So in the literature, we can find up to 84.4% sensitivity and 93.7% specificity of MRI to distinguish between glioma and other intracranial disease, which is quite comfortable. And in terms of other intracranial disease, we have to mention granulomas, because as we know, some of them will really appear like a glioma. And there is this very interesting paper out there that gives us some ways to distinguish between these, what they call the glioma mimic granulomas and the real gliomas. So that's the first thing. Then we have to distinguish glioma from other ring-enhancing lesions, such as the ring-enhancing abscesses. And again, the literature helps us with that, because there have been a publication about how to distinguish between a ring-enhancing abscess and a glioma. And this is also very interesting, because one of the key features to distinguish the two is actually in the late phase, in the late acquired post-contrast sequences, so which is not always routinely performed. But for further studies, I think it would be very interesting to perform it more on a routine basis. So basically what they say is that this ring enhancement tends to stay the same in abscesses, when in glioma it tends to move a little bit towards the center. So this is really interesting. Glioma have also to be distinguished from cerebrovascular accident. And again, we have a very interesting paper that got interested in finding features that distinguish glioma from these infarcts. And for this, the use of diffusion-weighted sequences is really useful, because this is where we are going to have more information, and we're going to have more argument to say this is most likely a glioma, or this is most likely an infarct. Of course, the signalement and the clinical signs also helped for this. So, of course, all of these features are not going to reach, we are not going to reach a definitive diagnosis with MRI. We are not even hoping to reach one. But with all of these features, we can be a little bit more confident in this challenging task, which is making the diagnosis of oligodendroglioma. And also, we have out there features to distinguish oligodendrogliomas from astrocytomas. So we have really all the information we need for that. In terms of prognosis and treatment, as I mentioned in the beginning, this is the end game. This is the main goal, because we suppose that, or we assume that what is described in human medicine, with low-grade glioma being a little bit more responsive to treatment and showing a longer survival, we are hoping that it would be the same in dogs. Another very interesting recent study actually focused on finding MRI features that were associated with a longer survival. And some of these features were the poor margination, an irregular margination, a more heterogeneous appearance of the tumor, and the presence of drop metastasis. And these features were associated with a poor prognosis and a shorter survival. And interestingly enough, these features were found in our group of high-grade gliomas. So the goal for all of this would be to improve treatment and provide adequate prognosis. The most interesting would be to spot these low-grade oligodendroglioma and try to provide a more accurate prognosis for them. And the second goal would be, as I mentioned before, to act as surrogacy in terms of when a brain biopsy is performed. So nowadays, there are more and more stereotactic brain biopsies being performed. Actually, we also do it in my institution. And the problem with a biopsy is that it doesn't represent the entirety of the tumor. So having these features on MRI could help maybe target the areas of contrast enhancement during biopsy, or it could also help in case of non-conclusive biopsy, where maybe on this slide there is no microvascular proliferation seen, but if on MRI we see spots of very strong contrast enhancement, we could maybe suspect that we are dealing with a higher grade oligodendroglioma. So very interesting future use for that. In terms of limitation for our study, the low number should be mentioned, even though we reach quite a very long period of time. We are exposed to this disease probably more than in other centers, but it remains a rare disease. So it is a low number. And the other thing would be the uneven ratio between the high grades and the low grades oligodendrogliomas. However, this ratio is described in the literature and also in studies about histological findings of oligodendrogliomas. So we expected and we know that there is less low grade than high grade in the nature. The second limitation to the study would be in regards of the diffusion-weighted sequences, because as I mentioned before, nowadays we try to identify features in the ADC maps and diffusion-weighted sequences that we are now performing routinely, but some of the patients that were included in the studies had an MRI performed at the time when we had a 1 Tesla magnet, and on this magnet, the ADC map is just very distorted, and we couldn't really do quantitative analysis of the ADC value, which is a regret of mine, because I do believe that it would be really helpful to do that for future studies. So if someone would be interested in continuing this study, I would really advise to include quantitative values of the ADC to be a little bit more precise in that sense. So in conclusion, this says it all. So here we have MRI that shows this high-grade oligodendroglioma with all these features that we saw in our studies, meaning it is a well-defined, smoothly marginated, ovoid intracranial mass. It is in the frontal lobe, which is the most affected. On pre-contrast, it shows this heterogeneity and with these cystic structures. And then on post-contrast, we see this very thick enhancement peripherally, compatible with a ring pattern. So I thought this was a good summary of the findings. I would like to thank you for your attention. Thank you, Laurent, for inviting me tonight. And I would like to also thank all the people from my department and Bern University for helping me through this study. And now I'm available for questions.
Thank you so much, Benedict. You did great, and your study is extremely interesting. And I really like the point that you make, because I do believe the same, that oligodendrogliomas behave differently than astrocytomas. I think it's quite important to, that would be great to have a study where we can compare the two of them, because that would be really useful. And this is just a question, if you don't mind, myself, it's just a curiosity. So I have, and I see that when I read your paper, you say that there are some that they have an intraaxial location, most of them, and others an extraaxial location. My impression is that oligodendrogliomas, they tend to be more in contact with the ventricular system than astrocytomas, and they tend more often to invade that and cause metastasis. That it can be drop, or it can be just diffuse ependymal or meningeal enhancement. And how often have you seen that in your study? And were all those high grade if you saw them, or there were some low grade as well?
So regarding the drop metastases, we only saw them in high grades.
Mm-hmm.
We never saw them in low grades, but the number of cases where we saw them was quite low. And I agree absolutely with what you mentioned about the localization of oligodendroglioma, because it is also my impression that they are more in contact with both the ventricular system, but also with the meninges.
Mm-hmm.
And also, I've rarely seen oligodendroglioma in more caudal locations, where astrocytoma I've seen.
Mm-hmm.
So this would be maybe another point that would be interesting to check for. I do believe they behave really differently, and the next step from the study actually would have been to only study astrocytomas now. However, they are also more rare. So this is also the reason why we started with oligodendrogliomas, because already 32 cases is not so much. But if we would talk about astrocytomas with just our center, we would be a little bit below that.
Yeah.
So yeah, that's the reason why.
And I also like the point that you made about the ADC values and to do a quantitative study. I think this is quite important. Yeah. And perhaps one thing that maybe in future studies you can do is because it's really nice to use the T2 star, the gradient echo. But when you use the susceptibility weighting imaging, you can also see very nicely apart from hemorrhage, the neovascularization, and perhaps that will be quite interesting to compare the degree of neovascularization with the degree of enhancement, and even if that neovascularization seen on the susceptibility weighting is even more correlated with the histopathology.
Yeah, I agree.
So now I don't ask myself anything else. So Laura Andrea is asking if we CSF findings taken into account in the study.
Sorry, can you repeat that?
If you did any CSF analysis, or if you had any results of the CSF.
Yes, so we perform CSF on all our patients that go to MRI. So we have the results. We chose not to include the results, maybe because we had a little bit more diagnostic imaging approach, let's say. And as radiologists, we are often a little bit frustrated with the results of the CSF. But most of the time they were normal, let's say it like this. So I'm not saying there is no possibility to find something there, but in my experience, I rarely had something interesting. Yeah.
Benedict, I have a question from myself as well. Excellent talk, by the way. It's really, and the study is very well constructed, very robust. I really liked it. So congratulations on that. I would be interested in knowing, did you look at any of these cases and think, whoa, I'm not sure I would have called that an oligodendroglioma or even a tumor? Were there any of them that surprised you that that's what you were looking at, or was it all fairly clear cut?
They were very homogeneous group of tumor.
They were, yeah.
Yeah, that's also why I think that if we take them individually, if we separate oligodendrogliomas from astrocytoma, we might have a more homogeneous population, and that's also why I believe we would reach a result like this, because they were all very, very similar in appearance. So,
Yep.
Very good. Thanks a lot, Benedict, for everything. I was just, keeping an eye on the question, but I'm afraid, and thanks. Thankfully for you, there is no other question, from the audience. I don't know if either Simon or Ines have any other question you wanted to put to Benedict.
No, that was it for me. I was very impressed with it. It was excellent presentation.
Carry on the good work, Benedict.
Thank you. Thank you.
And we look forward to read more paper from you, especially if you manage to, grab all this rare astrocytoma. I think it would be really useful, as well. Another study that would be worth is to, there is, I think, a gray area sometime between high-grade oligodendroglioma and GBM as well, glioblastoma multiforme, and it'd be nice sometime to know when, I think we diagnose the extreme when the GBM is, has evolved for a long time, but obviously there is a point where it's not like that, and when do we shift from one to the other one? That would be, I think, an interesting, one as well. Lot of, congratulations for your excellent presentation from all the people listening to you, and I will leave the last word for Simon to close this session.
Yeah, thank you very much. Thanks, Laurent. Thanks, Ines, as well, for being our co-host here. And thanks very much, Benedict. It really was a fantastic presentation and a great publication. If anyone wants to get in touch with Benedict to join forces and do future studies, then feel free to drop a line to the Facebook. We can forward your contact to her. I think your contact details are in the paper as well, but we can do that. Thanks to Hallmark Advanced Veterinary Imaging for sponsoring this session. Next time we're up at the beginning of June, and we're going to talk about MRI of feline disc disease. If anyone wants to present a upcoming MRI-based publication later on this year, please get in touch with us. We want to really give this platform over to you, young rising stars, and tell us what studies that you're doing. So thanks very much again to everybody for tuning in, and we'll see you next time.
Good night.
Bye-bye.